It's a pleasure to be back here again, guys. I have a lot of respect and value what you guys do. I think you work at the hard end of the psychotherapeutic work. I've worked all over Sydney, and I've seen how traumatised people behave. But some people move away because they find it overwhelming, and it seems that you guys continue the good work and stay working with these very demanding people. I'm not going to provide any solutions today. I don't think it's easy to sort of tell people how to take good care of themselves. All we can do is make suggestions that people can take up in their own time. How do we take care of ourselves when we work with the people whose lives have been severely disrupted after they've been exposed to kind of stimuli that have overwhelmed all their coping strategies, and it leaves them feeling disconnected from themselves and everybody around them? Their inner world has been so shattered that they can't behave like normal, whatever normal is meant to be. They can't behave like normal human beings. The reasons for their presentations may not be immediately obvious, or their presentations may not make easy sense to us. Having lost all their connections, sometimes their only option is a physical or somatic presentation. When we don't realise what's going on for them, we're likely to relate to them in ways that are more likely to unwittingly add to their trauma. Oh, the mic.
Thank you.
If this happens, then it's a terrible outcome for both our patients and ourselves. So how do we prevent this from happening? Well, clearly by taking better care of ourselves, because we're the primary tool that we use in the treatment of all these people. How do we take better care of ourselves? By actually knowing what we're doing. We kind of assume that we know what we're doing, but maybe not as in a detailed way as we sort of sometimes need to. What are we doing? We're clearly trying to help people with trauma. And what are we using to try and help them? Our relationship with them. So we're using our relationship. Now, everyone seems to think they know what the relationship is, and the only person who I know that doesn't know what a relationship is me. Every time everybody talks about it as if it's a third thing out there independent of the two people. A relationship is two people interacting, and it's everything they're doing with and to each other whenever they are together. So the relationship is everything two people do. It's not independently of them. They are the relationship. Every time we spend time with anybody, the opportunity arises for us to realise several things. We are not the same as them. They're not the same as us, and that we are different. So each of us brings something different to the exchange. Sometimes these differences are unexpectedly large. And sometimes we behave and sometimes we don't behave as if we're aware of these differences. If we're not aware of these differences and don't know how to manage them, we probably react defensively to cover our ignorance, and dare I say that in this space we are unaware that we can't take care of ourselves, or that we're not taking care of ourselves. So if we can't take care of ourselves, we can't take care of anybody else. So the more we know about ourselves, in other words, what we bring to the relationship, the better we'll be able to take care of ourselves. The more we appreciate the differences others bring to the relationship, the better we're able to manage our relationship with them. And the better, excuse me, and the better we're able to manage them. So managing ourselves and managing our relationship with them leads to managing them better. The more tortured and traumatised the people are who seek our help, the more different they are likely to be to us. So the better we have to know ourselves, and we have to know our strengths and weaknesses in order not to harm them. So we can think of self-care as knowing as much about ourselves as possible. The more we know about ourselves, the better we can take care of ourselves in relationship with every other. And because other human beings are similar to ourselves, not the same, but similar, the more we know about ourselves, the more likely it is that we will know more about them. The more we know about how we relate to each other, the better we'll be able to take care of them. So it's always knowing about ourselves, knowing about the other, knowing about the relationship, and that gives us a good foundation for taking care of ourselves, which is a prerequisite to taking care of them. So, what do we have to know about ourselves? Like everything. You might say that, how can you know everything about yourself? Well, okay, as much as possible. So what we think, what we feel, and how we behave, that's the content part of the exchange, and how we think and how we feel and behave, and that's the process. So it's the what and the how. So there's a content to it and there's a process. In an ideal world, we would know as much as possible about why we react the way we react to every stimulus that we encounter. Now that's never going to be possible, but in an ideal world that would be nice. Why? And we also have to know why we don't always react the same way to the same stimulus. So a different person presents a very similar or identical stimulus and we react differently. So what causes us to change our responses to the same stimulus when we see them in a different context? So transference and countertransference, I'm going to suggest, are technical terms that unfortunately have been much used and abused. I think that they're used in ways that obfuscate the simplicity of what they actually refer to. Whatever life experience each party brings to the therapeutic encounter, whether they're aware of it or not, so we're not always aware of what we're actually bringing to the moment, because each human being is different, we can't assume that somebody else is going to understand things our way and behave like us. So why do we get so bamboozled and tend to blame patients and think that they're the problem when we don't understand them, whilst expecting them to understand us? So one way of understanding today's topic is to think of transference as how we relate, how people relate to us, countertransference, how we relate to the people relating to us. Professional boundaries we can think of as what we collectively expect regarding how each of us ought to relate to our patients, both inside and outside of therapy. And self-care, I like to suggest, is knowing how to manage all of the above simultaneously. I'm sure you all have your own notions of transference and countertransference, but you can see that what I'm doing is equating transference and countertransference. In modern theory, making that distinction is pointless as far as I'm concerned. In a general sense, everything about today's topic is about relationality, how we relate to ourselves, how we relate to others, how others relate to us. In a specific sense, how we relate to ourselves and take care of ourselves when dealing with some of the most disrupted human states that emerge in survivors of torture and trauma. If anything is going to confront us, if anything is going to challenge us, it's these people. We can think we're well-integrated human beings and we've got all our defences and coping strategies in place, and we've seen hundreds of these people, or whatever number you've seen, and you feel safe and secure that you're doing really, really well, and then right out of left field, somebody drops something and you freeze. And you freeze. You can't work out why the hell you're frozen, because your perception of yourself is that you know an awful lot about these people because you've been dealing with them for so long, and you can't work out what is so different about this person where I've just frozen. So the best way to take care of ourselves in these situations is to know as much as possible about ourselves and how we function. What we're doing, why we're doing it, what can go wrong, and I'm talking about therapy here, how we can repair whatever goes wrong when we are in relationship with these severely disrupted human beings. In order to know as much as possible about how we function and react in relationship to these people, we have to also know as much as possible about why these people present and behave the way they do. So we can know about ourselves, we have to know an awful lot about why they behave the way they do. So we have to know an awful lot about traumatic states, what generates them, how they present, and I've only just given just a very brief reference to them: fragmentation, dissociation, somatization, how and why we react to their presentations the way we do, and we've got to know how to repair them. We've got to help repair these people. We have to relate to them in ways that provide some restoration of an integrated sense of self. Now, within the relational paradigm of therapy, therapy is not something that we do for the patient. It's something that we do with the patient. We do something with the patient. Our job is not to provide insight, giving them information, things that they don't know. Our job is to provide a kind of relatedness that helps move them from disrupted sort of regressive states to more mature states, which will allow them to access their coping strategies, which have been destroyed by their overwhelming traumas. So a little bit of history, not too much. I don't think the history of transference and countertransference is very good. I think it tends to be very obfuscating, unfortunately. The traditional view has largely been traditionally, transference is thought to be largely intrinsic and independent of the therapeutic relationship. It's something that belongs to the patient and has nothing to do with us. But I think a more trauma-based and relational perspective, it's extrinsic. It's triggered by what happens between us and the patient every time we get together. So we're actually triggering that response. The person isn't sort of being triggered, they're not reacting. We have actually provided a trigger that they're responding to. So it's not them, it's us. These are Russell Mears's work. I don't know how many of you folks might be familiar with Russell Mears's work, but he's kind of like the author of the conversational model, and was the professor of psychiatry at Westmead Hospital for 35 plus years. He's written 6 or 7 books, and he's got about 1,000 papers that he's written about therapy. And he says that the therapist-patient interaction triggers or activates a traumatic experience from the past that has been stored in memory but not be able to be recalled. So if you've had a traumatic sort of like experience that you can't recall, or you have behaved in ways that you can't recall, and you're sort of talking to your therapist, and your therapist doesn't realise that you can't recall and you can't connect the way you're presenting to him or her, then your therapist can get it horribly, horribly wrong. Now, what are the consequences of not recognising the countertransference? You may as well ask at this point, if I don't like the word transference and countertransference, why do I keep on using it? I keep on using it because everybody uses it, and I'd rather sort of say all the thoughts and feelings and all our reactions and all our coping strategies that we bring to the moment. That's from a therapist, and it's exactly the same for the patient. If the therapist is not immediately aware of what's going on, if he doesn't recognise that the patient has been triggered by something that has happened in the moment in therapy that has been historically associated with something traumatic that's happened in the past, then the therapist will not be able to understand why the patient is relating to him or her as if he or she is the abuser. So the therapist's response will more likely than not be inappropriate. So you're not aware of why the patient is thinking, feeling, behaving the way they are. So how are you going to target your response if you're unaware where they're at? So it's likely to be inappropriate, which will then confirm to the patient, because you're off the mark, that the therapist has got no idea of what he's doing, and then that's the proof that the therapist is re-traumatising him. And in fact, we are re-traumatising people. If we don't know what we're doing, we are re-traumatising. We think we're actually doing good therapy. Additionally, the therapist's own response may leave the therapist confused as to why he has responded in the way that leaves the patient feeling traumatised. Shit, what did I do? You know, why is my patient behaving like this? In these circumstances, a therapist may feel at odds with himself, as if he's done something that he didn't expect himself to do, and unable to explain what made him feel and behave the way he did, or she did. So these states can disrupt us in such a way, so we lose track of why we're doing what we're doing. In these situations, it can be easy to assume that the patient is the problem. And therein lies my problem with classic analytic theories, that they always have some explanation that absolves the therapist of responsibility for what's happened and always blames the patient. And in those moments, even those of us that aren't sort of like, classically trained, I think that these moments are so overwhelming that if we don't know what we're doing, we're likely to think that it's the patient that sort of is the problem. And we might think like this: I didn't traumatise him. He feels traumatised because he's been traumatised in the past and thinks that everyone will continue to traumatise him. This approach, I'd like to suggest, leads us to not recognising that we have done something, in other words, provided us the stimulus or a trigger that our patient associates with trauma. It's not in the patient's head, they're not to blame, they've not imagined what we have actually done. We actually did something that evoked their traumatic response, and in that sense, we are to blame. We have re-traumatised them. If we try and understand and explain what happens in these moments, we can approach this challenge from a variety of perspectives. If we approach the task from a theoretical perspective, we will find a variety of answers that reflect the prejudice and ignorance of each theoretical model. If we want to avoid the endless self-congratulatory storytelling associated with non-relational models that have no scientific basis for their theorising, then we're left with very, very few options. Have I offended enough people yet? To my mind, the simplest and most powerful explanation comes from an understanding that we are our prior experiences, we are what we have learnt, whether we can remember what we've learnt or not. And at this point, it's important to remember that those experiences that are essentially, I'm going to call loosely called pre-verbal, we can't recall. And we can't recall them because they're at a stage in our development where we lack symbolic function, so we can never manipulate these experiences symbolically, so we can never actually do anything with them. And they're part of a memory system that we don't have access to. So we have experiences that shape our lives that we can't recall. So we're at a loss as to what to do when where that part of ourselves has been engaged with in therapy. The whole notion of learning is about using what we have experienced in the past to help us better manage similar circumstances in the future. And after all, transference is about transferring what happened in the past to the present and to the future. And after all, why shouldn't we call it just learning? Why do we have these fancy words that talk about transference and countertransference? One of the biggest problems human beings face is that when they're confronted by experiences, is when they are confronted by experiences that they've never had before. So all our knowledge and all our experience and all our expertise doesn't count. When all of a sudden we're confronted with something, it's like the black swan. If you've never seen a black swan, somebody trying to tell you that there's a black swan, until you see a black swan, you don't know what a black swan looks like. And when understanding our own that's when understanding our own reactions can become quite challenging. So we're having experiences we never had before, and understanding why we're reacting to this new stimulus, the way we're reacting, is quite challenging. That's when it's useful to have some jargon that we can throw at the problem that hopefully will suggest that we know what we're talking about. So on the 8th day, God created transference and countertransference. The problem with the old explanations of transference and countertransference are essentially very simple. Tragically, as far as I'm concerned, people think that there is such a thing as transference and countertransference. There is no such thing as transference, as countertransference. There are phenomena that we experience, and then we've just labelled them, and then we use the label in the same way as the phenomenon, and we get really confused and we go around talking as if there is such a thing as transference. There isn't. It doesn't exist. It's a construct, it's an explanation about something. It's not, some sort of entity in itself. Russell Mears offers an alternative explanation that requires just simply an understanding of normal development, the working of memory and the effects of trauma, all scientifically based. No storytelling, just simple, you know something about developmental history, what human beings are capable of, you know how memory works, you know what trauma does, it disrupts everything, then you can make better sense of what's going on for you and your patients. He invokes the notion of priming and it relates to when we respond with recognition to a stimulus that we've previously been exposed to but we're not consciously aware of. The stimulus that we've been previously exposed to that we're not consciously aware of. Isn't that most of our lives? It is mine. Then he sort of elaborates that, and I put it in to just show you how, even though Russell has simplified it all, how complex you can get caught up in theorising. He then goes on to say, priming reflects the operation of an unconscious system of perceiving and remembering, which is distinct from that of consciousness. And it's reasonable to speculate that such a system has a part to play in the therapeutic conversation, during which at times the therapist may act or will tend to act as if he or she has been constructed to play a particular part. I don't know how you guys respond to a little bit of text like that, but I find that really confusing. He simplifies things and then he just sort of complicates things again. Keep it simple. Okay, then he also talks about expectational fields. Have you come across that idea, expectational fields? Okay. Nothing complicated. Every time we come into a therapeutic interaction, my God, every time we have a conversation with anyone, we bring our expectations with us. We all have expectations about everything. We have expectations of ourselves, we have expectations of the people that we're talking to. Our past experience about X will inform us regarding what our personal options are next time we come across X. Okay? Past information, you use it, you see the same thing again, you use past information. Society and culture also have rules about what we should do next time we come across X. So we all know what is expected of us next time we come across X. This is just simply learning from past experience. So we all have expectations of ourselves and others, and we will continue to behave we all have expectations that we will all continue to behave in anticipatable ways next time we come across X. So both parties have an expectation on how each should behave when they both face X. The problem arises, of course, when we don't recognise our own expectations or those of the other person. The most common reason why we don't recognise each other's expectations, our own and each other's expectations, is because we ourselves are in trauma and can't access our own awareness of ourselves, let alone the other person. So if we can't access our own awareness of what we're doing, my God, we're in strife, aren't we? How often do we get in strife? The worst case scenario involves, in that little context that I just referenced, what we can think of as interlocking trauma systems. So if my patient's in trauma, and then as a result of what's going on between us, I also go into trauma, each party triggers the other person's trauma system, both of us are unaware of what's happening, so we're both unable to understand why each other's expectations aren't being met. So that neither of us, patient and therapist, can't take care of themselves, so they can't take care of each other. That might be a weird way of putting it, because we as therapists, of course, don't have any expectations that our patients ever take care of us, right? Okay, a bit of a summary. So what I'm really saying is that in order to take care of ourselves, we all have to become better at understanding or unscrambling the complex reactions and interactions that we get caught up in during therapy. Most theories are not particularly helpful because they seem to impose an unscientific understanding on what happens next in therapy. The conversational model, plug, reduces infinite complexity to the basics, which is what I said before, that we are what we've experienced and all that we've learned. And this stuff, all that we are, all that we've experienced, all that we learned, remains stored in our memory systems, whether we are aware of it or not. Now, my little expansion of kind of like the conversational model is to suggest that it might be helpful for us to think of relationality as a language. If we begin to think of the way we relate as a language, and we learn a language, and we learn to speak a language, and we learn that language when we're very young from 1,000 different sources. So, if we think of relationality as a language, why do we find it so hard to recognise the different languages in therapy? That was a question, but I don't know what the answer is, so I'm going to ask some more questions. It's a bit like asking, why do the French speak French? Why do the French speak French? Eh?
Because they're French.
Because they are French? Isn't that interesting? It's because they were taught French. So it's a trick question. You knew the answer. Why don't we all speak French? Because we weren't taught French. Why don't we recognise when somebody's speaking a different language? So we're speaking English, but even as I'm talking to you guys, I'm not speaking the same language as you. See, I'm making these horrific assumptions that you actually understand what I'm saying. Do you realise that every time we use a noun, we make assumptions about what that noun refers to? If I sort of said, I can have 5 chairs in my room, and I say, can you please go get me the chair, because I'm going to say the chair, just to confuse you, which out of the 5 chairs do you choose? In my mind, I expect you to bring the black one. When you bring in the yellow one, I say, how stupid are you? I meant the black chair. You're supposed to know me well enough to know that I mean black chair every time I say chair, because historically that's the only way I refer to chairs. But that's not what happens. So what happens to us when we've been speaking English to a person who only speaks French? How many people have been to France and tried to speak English to the French? I was there 15, 16 years ago, and we went in for our first breakfast, and my wife speaks a little bit of French, and I thought I spoke a little bit of French, clearly not. The woman could speak English. My wife orders in French, I order in English, and she proceeds to ignore me. Then my wife has to order for me. We go back every day, I order in English, she ignores me every day for the next 6 weeks. Okay? Now, what happens to our patient who only speaks French when we have been speaking to them in English and haven't recognised that we've been doing this? Some circumstances are intrinsically frightening, I'd like to suggest, and capable of provoking paralysing fear and dissociative anxiety that leaves us incapable of looking after ourselves. I'd like to suggest that being in a situation in which we haven't been speaking the same language as the other person may be one of those scenarios. If somebody's talking to you as if you should understand what they're saying and you don't, is it unreasonable to feel confused, anxious, scared, frightened, discombobulated, as if there's something wrong with you? Maybe you might even feel traumatised. Because you can't make sense of how and why the other person is relating to you, is it unreasonable for you to expect that the other person knows what's going on for you and knows that he has done something to re-trigger your trauma? Yeah, interesting questions. But from whose perspective am I asking it? Am I asking about it from the therapist's perspective or from the patient's perspective? The question is there any difference? So, how do we take care of ourselves in these circumstances? Thank you very much.